Hello, my name is Robert Flynn. I'm a consultant urologist in Tala and Beacon Hospital, and as a robotic surgeon I spend a lot of my working week looking after men with prostate cancer. I've been asked by the Irish Cancer Society to answer some of your questions around prostate cancer. One question I've been asked is, can prostate cancer be cured? And in a word, yes. However, like so many other cancers, the likelihood of cure is highest if the cancer is detected early and still confined within the prostate gland itself. For those men who are diagnosed with prostate cancer, after the diagnosis, the next hurdle is often one of shared decision-making in terms of determining which is the most appropriate treatment for an individual. For those men who present with prostate cancer beyond the prostate, the good news is that there are a lot of newer treatments, both hormonal and chemotherapies, that prolong life and improve symptoms. Are there modifiable lifestyle changes that I can make to reduce my risk of prostate cancer? Unfortunately, there aren't. Prostate cancer is unusual in that there aren't many modifiable risk factors. The most significant risk factor is age, and I previously mentioned that prostate cancer is much more common as you become older, and also family history is very important. In terms of healthy lifestyle, i.e. watching one's weight, smoking cessation, avoiding alcohol excess and exercise, these are all strategies, however, that can be used to help you through your treatments and reduce the side effects of any treatments that you might ultimately require. What are the symptoms of prostate cancer? I think this is difficult because for most men with early prostate cancer, there are no symptoms. As the man gets older, however, his prostate will enlarge, and this can often cause urinary symptoms, which are felt to be independent to early prostate cancer itself. It's often the urinary symptoms, however, that trigger a PSA or a prostate blood test. For men with advanced cancer, yes, symptoms are more common, and they're often generic in terms of generally feeling unwell, weight loss, and back pain. But for early prostate cancer, there are no symptoms, and the main way it's detected is with a raised PSA or prostate blood test. Why is prostate cancer common as you get older? And I'm afraid nobody knows the answer to that, but it's certainly observed that prostate cancer is much more common in older men. Prostate cancer is rare before the age of 50, and indeed most men who are diagnosed are 65 plus. One problem we do encounter is trying to make a decision around investigating older men who either have an abnormal PSA, i.e. prostate blood test, or their prostate feels abnormal. This needs to be, again, shared decision in terms of taking the whole patient into account, in terms of their general level of fitness, comorbidities, and overall life expectancy. A lot of older men with prostate cancer will die with their cancer rather than from it, and therefore, in a lot of older patients diagnosed with prostate cancer, a different approach will be taken to the younger man. I'm at an increased risk of developing prostate cancer if my dad had prostate cancer. To put this in perspective, a white male has about a 1 in 8 lifetime chance of developing prostate cancer. There are huge ethnic variations in risk, and black men have a 1 in 4 chance of being diagnosed with prostate cancer. If your dad was diagnosed with prostate cancer, particularly before the age of 65, you probably have double the general population risk, which is quite significant. There are a small percentage of prostate cancers, probably in the order of 5%, which have a genetic rather than a familial risk, and typically those men will have been diagnosed very young, i.e. before the age of 50. And likewise, there may be a family history of breast and ovarian cancer, which are associated with a similar genetic abnormality as genetic prostate cancer. What treatment options are available for prostate cancer? I'm going to keep this simple. If we talk about disease confined to the prostate, the two main treatments are either surgery or radiotherapy. In terms of surgery, in this country, most men will be offered a robotic-assisted laparoscopic radical prostatectomy. Other options include, however, pure laparoscopic surgery or open surgery. In terms of robotic-assisted and laparoscopic surgery, there are some short-term advantages, particularly in terms of quicker recovery and return to normal activity, and they are at least equivalent in terms of cancer eradication, continence, and return of sexual function. In terms of radiotherapy, the two main treatment options are either external beam radiotherapy or, in suitable cases, brachytherapy, which is a single one-off treatment where radioactive seeds are inserted into the prostate. For disease beyond the prostate, the options are either hormonal or chemotherapy. Again, sometimes radiotherapy may be used to the prostate and local lymph glands, or occasionally, where disease has spread to a relatively low volume of sites beyond the prostate, radiotherapy may also be used then also. How is prostate cancer diagnosed? Like most cancers, prostate cancer is diagnosed with a prostate biopsy. And normally the trigger for that biopsy is an elevated prostate blood test, or PSA. Less commonly, it might be an abnormal feeling prostate, or in rare occasions, the trigger might be that somebody is presented with symptoms suggestive of disease beyond the prostate. What is new in recent years is that most men will have an MRI scan before proceeding to a biopsy. This has two main benefits. One is that roughly a third of men can avoid a biopsy, as the MRI shows an enlarged gland and nothing suspicious within it. If a man's PSA is consistent with their prostate volume, often these men can go on observation and not need a biopsy. For those men that have an abnormal focus or area within the prostate that's suspicious for cancer, those men can then have a more targeted biopsy, which means these days we're doing fewer biopsies for men who don't have cancer and less likely to miss the cancer and avoid what we call a sampling error. Something else that's changed in recent years is that in the past, most biopsies were done through the back passage or transrectal biopsies, and these had a significant risk of infection. These days, most biopsies are done transperineally, i.e. through the skin in front of the back passage, and here the risk of infection is almost zero. Can prostate cancer recur? And the answer to that is unfortunately yes. Just like many other prostate cancer, there is a risk of recurrence. In terms of recurrence, the prostate cancer can return within the prostate itself after radiotherapy, or in the prostatic bed, i.e. that area deep in the pelvis where the prostate was before it was removed. Or the cancer can recur at a distant site, most commonly in the lymph glands or in the bone, known as metastatic disease. The likelihood of recurrence is dependent on the grade of the tumour, i.e. how aggressive the tumour was, the stage of the tumour, i.e. if it was confined to the prostate at the time of initial treatment, and also if you've had surgery, on whether or not the margins were clear, i.e. was there any cancer on the surface of the gland or the tissues that were taken around the gland at that time. In terms of observing for recurrence, it's normally detected by a rising PSA or prostate blood test. A rising PSA is normally the first abnormality that triggers the suspicion of recurrence. If someone has a persistently rising PSA following treatment, this often will trigger further what we call scans in the form of CT, bone scan, and maybe a PMSA PET scan in an effort to try and detect the area of recurrence and offer the most appropriate treatment for the recurrence. What are the long-term side effects of prostate cancer treatment? If we talk first of all about surgery, in surgery, a lot of the side effects are front-loaded to the early days following surgery. But in the long term, there are some side effects, and the two main ones that bother patients are the risk of urinary incontinence or bladder leakage and the risk of erectile dysfunction. About 3 to 5% of men will not regain good bladder control, and a certain percentage of those men will go on to have other surgical procedures to correct that. Whether or not erectile dysfunction develops in the long term depends whether or not a man has had a unilateral, bilateral or a non-nerve sparing procedure. Preservation of the erection nerves increases the chance that erections will come back, but is not a guarantee. With external beam radiotherapy and to a lesser extent with brachytherapy, the development of urinary symptoms is pretty minimal in the long term, and certainly urinary incontinence is not normally an issue. Certainly erectile dysfunction can develop with time but tends to come on more slowly than with surgery. A small percentage of men will develop long-term bladder and bowel issues, either in change of bladder and bowel function, or less commonly in about 2 to 3% of men, they will develop long-term passage of blood in either the urine or in the bowel motion. Hormonal treatment has its own side effects. Hot flushes are common, weight gain, breast swelling, erectile dysfunction and fatigue. And in the long term in particular, the risks of osteoporosis and chronic anemia can be issues. Why are so many GPs reluctant to do a PSA test? I'll try and answer this question in a somewhat roundabout way, but I do feel that as the years have gone by, the reasons for not doing a PSA are dwindling. I think one concern that GPs had is that while the lifetime risk of developing prostate cancer is about 1 in 8, only about 3 to 4%, i.e. 3 to 4 per 100 men, will actually die of prostate cancer. The other issue is that up till recently, about a third of men diagnosed with prostate cancer had what we would consider are clinically insignificant prostate cancers, i.e. cancers that are unlikely to progress, cause symptoms, or need treatment during a man's lifetime. One concern of GPs and indeed urologists is the over-treatment of these insignificant cancers. In fairness, with the introduction of pre-biopsy MRI, which is unlikely to detect low-grade cancers, the percentage of low-grade cancers that are now diagnosed is reduced. And there is the option of active surveillance, i.e. non-treatment, careful observation of men who have low-risk cancer, who then can often avoid treatment and any treatment-related side effects. Another piece of information that I think needs to be factored into this decision-making is the results of the European study of screening for prostate cancer. This was a large multi-centred trial of over 180,000 men, which has been shown to reduce the mortality from prostate cancer. This obviously comes at a cost, both financial and human. And indeed, roughly 570 men need to be screened to detect one cancer, and 18 men need to be treated to avoid one cancer death. So I think it's very reasonable to do a PSA, but as long as the patient's adequately counselled and understands the pros and cons of a PSA, and that a PSA is only the start of the journey, and that one is likely to need an MRI and very often a biopsy to clarify matters.